Okay, so good afternoon, everyone. Welcome to this webinar to launch NAP7. My name is Ramani Munasinghe. I'm the Director of the Health Services Research Centre at the Royal College of Anaesthetists, and the HSRC is responsible for the delivery of the National Audit projects. It's a real pleasure to welcome you to this webinar, which will discuss NAP7, which will be focusing on perioperative cardiac arrest. Our speakers today include Jaz Saw, who is the National Clinical Lead, Amira Kasumovic, Richard Armstrong, and Andrew Kane, who are the NAP7 Clinical Research Fellows. So they're all trainees in anaesthesia who are supporting the delivery of the project. And also Tim Cook, who may not be able to join us today, but you will all know Tim as the National Audit Lead for the Royal College of Anaesthetists. I've got a couple of housekeeping things to start with. So if you wish to submit questions or comments, please do so using the question and answer tab, which you should see on the bottom of your screen, probably in your Zoom window. If you're having audio or visual problems, please just exit and restart Zoom using the same link. And there will be a recording of the webinar available in due course. So without further ado, I'm going to hand over to Dr. Jaz Saw, the National Clinical Lead, to open the webinar. Thank you, Jaz.
Thank you, Ramani. So welcome, everybody. So as Ramani said, NAP7 is a clinical service evaluation of perioperative cardiac arrest in the UK. And before I move on, all these slides and all the information we're covering is available on the NAP7 website. So this is the first key message. The start date for the project is next Wednesday, 16th of June, 2021. So it's a year later than scheduled, but we're on target. We're going to start next Wednesday. And NAPs have all had 3 parts. And so NAP7 is no different in that we have a baseline survey, which is at the start of NAP7. And this consists of 2 parts: a local coordinator survey, which is departmental structures and processes about perioperative cardiac arrest, and then a survey of all anaesthetists and anaesthesia associates, which is about personal experiences of perioperative cardiac arrest. And every hospital in the UK has a local coordinator, and today or yesterday, they should have received a link to this baseline survey for all anaesthetists and anaesthesia associates. And the local coordinator survey will go out next week. So that's part 1. Part 2 is case reporting, and I'll go into that in more detail. This starts next Wednesday, and we want all cases that meet inclusion criteria to be reported to the local coordinator, who will then do complete a detailed case review form on a special website and a web link. So local coordinator gets in touch with the college sends a unique link, which is then completed. And these cases will be reviewed by the NAP7 panel made up of stakeholders. And we have stakeholders from all the various specialist societies, so Cardiac Anaesthetists, Neuroanesthesia, Critical Care Society, the Vascular Association, the Paediatric groups, the critical care groups, anaesthesia associate groups, and so on. So we have a large panel. So that's the second part. The third part is the activity survey. And this is a 4-day activity survey of all hospital sites in the UK. And we then multiply that up and estimate a denominator data. And for example, for NAP6, there were 3.5 million estimated cases done in the UK. And the denominator data will also include adverse events or precedents of cardiac arrest. So we'll count the number of difficult intubations or failed intubations, suspected anaphylaxis, severe hypotension, or hemorrhage cases. And this is just to sort of highlight what those particular sections are. it's important for NAP7 and all NAPs that all reporting is confidential and anonymous. And the reason that's important is that none of us involved in the project or at the college or reviewing the data, the panel members will know who's reported which case or which hospital a specific case comes from, or, so it is generally confidential. And clearly all the reporting, we ask people not to put in identifying data such as names or hospitals and so on. What about the scope? So it's quite hard to define cardiac arrest because in many cardiac arrests, people don't know precisely when the heart stopped beating. So the inclusion criteria we've used is one used in most cardiac arrest audits, which is, a patient receiving chest compressions and or defibrillation. We've gone on to say more than five or more chest compressions, just to not include patients who may have got just one or two compressions, for a bradycardia. And secondly, in a patient having a procedure under the care of an anaesthetist. So at least 5 chest compressions. These could be direct compression of the heart, standard compressions, mechanical chest compressions, or putting people onto ECMO or extracorporeal CPR that started during cardiac arrest. And Dr. Kane, Andrew Kane, will say a bit more about that later. What about defibrillation? Defibrillation is an unsynchronized DC shock from ventricular fibrillation or pulseless VT. It could be external, internal, manual, or an AED. It could be, shocks that were delivered by an implantable defibrillator. And after much debate, we've also included the precordial thump because I'm told some people still use it. It's no longer in the guidelines. And because it was something people wanted to know about, it'd be quite useful to know if anybody's had a precordial thump that's actually worked for a cardiac arrest. Under the care of an anaesthetist. So this is straightforward for quite a few cases, the majority of cases, but there are some grey areas. So this is patients having general anaesthesia, regional anaesthesia, analgesia, sedation, local anaesthesia, monitored anaesthesia care with an anaesthetist present, although we are also including anaesthesia associates, and then patients directly managed by an anaesthesia associate, as I've just said. Okay, this is just to specify the time window in a bit more detail. So this is any case that starts. So this is sort of midnight, Tuesday night going into Wednesday morning. So any cases occurring in the early hours from Wednesday morning would be included after midnight and going on for 1 year. Okay, what's the start time of the inclusion window? So cardiac arrest occurs after the WHO sign in with the anaesthetist or first hands-on contact. So we are sort of hoping that most elective cases and emergency cases will have a sign in. So the first hands-on contact cases will be where you call to an emergency, where you anaesthetize them to go to theatre, as opposed to patients who've come in electively or on the emergency list where, they should have been in most cases assigned in. And then when does the window end? And there was quite a lot of debate about this amongst the stakeholder panel. So myself as clinical lead just wanted to shut down the project when the patient leaves recovery. Some people said, well, perioperative is until they leave hospital. Others said 72 hours. Some said 48. So we've sort of reached a consensus on 24 hours after handover to recovery or handover of care to another clinician if you're taking the patient to ICU. Or if the patient leaves hospital within 24 hours, the point at which they leave hospital. So we're not interested in collecting data on patients who have their cardiac arrest after they've left hospital. Hopefully that's relatively uncommon, but clearly it's a difficult group to collect data on. And other national audits, such as the out-of-hospital cardiac arrest audits, would pick up those cases. So just an overview there. So that's the inclusion period. So we've got the pre-procedure location, we've got the checklist or hands-on contact. Most of these cases will be in theatre, but it could be elsewhere. And then at handover, a 24-hour period, and that's a close. And I'm hoping we'll get all the cases that occur in theatre, and then most of the cases that occur in this 24-hour period. And when you look at previous NAPs, it's often those fringes or the edges of the NAPs that actually get you some of the richer or more important data. And so those boundaries are slightly fuzzy, but it's the best. I think it's going to get us useful information about that 24-hour period after surgery or after handover or after leaving recovery. General exclusion. So if the patient's already in arrest before you attend, patients clearly, if they're already dead, we're not going to be interested in them, although some of these patients may have compressions or other interventions. I'm going to hand over to Amira now to just talk a bit about the obstetrics and paediatric aspects of NAP7.
Thank you, Jazz. So in terms of the obstetric population, this is quite a niche cohort. So we've had to adapt our definition for the perioperative period. So as Jazz said, so the start of the perioperative period will be the same. So from the start of anaesthesia care until 24 hours after delivery. What I mean by the start of anaesthesia care will be either first hands-on contact. So in the obstetric population, there will likely be when you about to perform an epidural procedure, or at the WHO sign-in in theatre. So whichever one comes first. Now, with regards to the 24-hour period after delivery, that could be tailored to the patient. So if the patient goes back to theatre, a new 24-hour period starts following the end of that procedure. On top of the general inclusion criteria, we would also like to include monitored anaesthesia care that's delivered in theatre. So any patient that an anaesthetist present is required in theatre, for example, for forceps delivery, when an actual anaesthetic intervention is not performed, we want to include. And any anaesthetist specialist analgesia that's administered for labour, so that includes spinal, epidural, combined spinal epidural, and remifentanil PCA administered on labour ward. What we want to exclude is any cardiac arrest that has occurred before the start of anaesthesia care or before the anaesthetist arrives, and when there's no anaesthetic intervention performed. An example of that would be if there's a patient on labour ward that has an antepartum hemorrhage or a postpartum hemorrhage and has a cardiac arrest before the anaesthetist arrives, and whereby no anaesthetic intervention has happened. Next slide. Thanks, Jazz. Moving on to paediatrics. Now we want to include everyone who's under the age of 18 and meeting the general inclusion criteria. But amongst the NAP7 sort of steering panel, we've identified that paediatrics is quite a specialist group, and critically ill children who require specialist anesthesia care for emergency procedures are high risk or regarded high risk amongst the anaesthetic cohort. So we've decided to tailor some specialist inclusion criteria. And what we're particularly interested in and want to include is children that are anaesthetized when there's a possible planned procedure. For example, when a child is admitted with epiglottitis and requires an airway stabilization in theatre and with ENT surgeons present, and now it may be that the patient doesn't need any ENT intervention, but is anaesthetized solely for stabilization. We want to include those patients. Secondly, also critically ill children that are anaesthetized in non-specialist centers. What I mean by that is hospitals that do not have a PICU, or pediatric intensive care unit, and that are anaesthetized and stabilized for an inter-hospital transfer or a retrieval team to arrive and take them to a specialist hospital. And the perioperative period for this cohort of patients includes from the start of anesthesia care until the patient leaves the host hospital. With regards to what we don't want to include amongst the pediatric population is newborn resuscitation. So those newborn patients that are delivered on labour ward or in theatre, and critically ill children that are anaesthetized and solely for critical care. For example, a child who with severe sepsis is anaesthetized for stabilization to be admitted to their own PICU. So there's an intra-hospital transfer. Thank you. And I think the next member to speak is Richard. So I'll pass over to him.
Thanks, Samira. So I'm just going to say a few words about the cases that are included and excluded within emergency department and critical care settings. So within the emergency department, we struggle to define the included population here, but essentially what we're trying to capture are the same group of patients that would be captured under the general inclusion criteria, in whom their anesthesia care starts in the emergency department rather than in an anesthetic room or in theatre. So for adult patients, it is those in whom a procedure is planned or likely who arrest before this is possible, i.e. they would have met the general inclusion criteria were they anaesthetized in an anesthetic room, but their care happened to start elsewhere. We are not including, and the following patients are excluded, those who are anaesthetized solely for critical care, so for stabilization and subsequent transfer to critical care unit. Those who are anaesthetized solely for diagnostic radiology, so for example, to facilitate CT head. And those who are anaesthetized with no potential consideration of a procedural intervention. There will be a patient group, and it was mentioned in the Q&A already, who are being anaesthetized in one hospital for potential procedure at another hospital. The inclusion and exclusion around this group of patients is that we are going to include patients in whom the procedure is in that base hospital. So if patients are being anaesthetized to facilitate transfer to another center for potential intervention at that center, they would not be included in that base hospital. They would enter the inclusion criteria as and when they reach the hospital where the procedure is going to take place. And that'll be clarified in the FAQs on the website and perhaps touched on in the discussion at the end today. Moving on from the emergency department, we have the critical care areas, intensive care units and high dependency units. If we could have the next slide. So regarding critical care patients, the first thing to say is that we are excluding patients who are having procedures delivered within critical care. So for example, percutaneous tracheostomy under the care of the intensive care or anesthetic team. Any procedures within the critical care area are not included. We will, however, be including patients who are being transferred under the care of an anaesthetist from a critical care area to another location in that hospital to have a procedure performed. Patients who are being transferred solely for diagnostic radiology will not be included. So similar to the emergency department setting, we are not classifying diagnostic radiology as having a procedure for the purpose of NAP7. So patients transferred for diagnostic radiology will be excluded. Similarly, patients who are being transferred either intra-hospital from one critical care area to another, or inter-hospital to another critical care area under the care of an anaesthetist, these patients will be excluded as they're not defined as having a procedure. And that covers the emergency department and critical care area. As I say, there is more clarification on the website, and if you have any other questions, you can type them in the Q&A and we can pick them up at the end of the webinar. Thanks.
Thank you, Richard. So I'm now going to cover some of the issues specific to cardiology procedures and cardiothoracic surgery, because there was a lot of discussion and concern at the steering group about lots of cases potentially being picked up in this area due to frequent use of, say, cardioversion and defibrillation in cardiac surgery. So firstly, focusing on cardiology procedures, first thing is to say that patient coming, for example, for a cardioversion would not be included, because a cardioversion doesn't classify defibrillation under the definition of NAP7. And there was also a concern about patients who are going for electrophysiological procedures, where it may be normal or expected for them to have a defibrillation during the case. And if that was the case, and say, for example, at the briefing, you thought it was highly likely that you're going to have to defibrillate a patient because they were already, for example, in VT, then that patient wouldn't be included in NAP7. But if you took a patient and you weren't expecting to do that, for example, for a simple cardioversion for AF, and they went into cardiac arrest and then had chest compressions or defibrillation, then that would be included. And then in terms of cardiac surgery, there was also a lot of concern here that a lot of patients coming off bypass might be in VF and get a shock, or they may be crashed onto ECMO or fail coming off bypass several times. These patients won't be included. So what we've said here is that pragmatically, that any patient who has an event such as defibrillation or chest compressions during the bypass period will not be included, in the sense that that event itself will not fulfill the criteria for NAP7. So the period at which we're going to define the bypass period will be from when the aortic cannula or arterial cannula is inserted until it's taken out following the bypass period. Now, that's not to say that these patients can't be included in NAP7 for other reasons. So they could, for example, have a cardiac arrest before they go on bypass that would fulfill the definition, and therefore they'd be included. And equally, after the bypass period, say they were in the cardiac ICU and they had a cardiac arrest, they could also be included at that point. And then finally, there's one specific special case really, and that's ECMO CPR. So this is, we know, only used in a very small handful of centres in the UK, but nonetheless may be reported during the NAP7 window. And these are patients who have a cardiac arrest and then are started onto VA or veno-arterial ECMO during the cardiac arrest. As I said, probably incredibly rare, but nobody knows how rare, and that's why it was felt important to include it. But the key thing is to say that these patients are already going to fulfill the definition for cardiac arrest, in that they will have had cardiac compressions, chest compressions, and or defibrillation. If you're just moving a patient onto ECMO who, say, fails to come off bypass or is in a low output state but doesn't have cardiac chest compressions or defibrillation, then they wouldn't be included unless they fulfill that criteria. With that, I'm going to hand back to Jazz, who's going to summarise.
Okay, so thanks to Amira and Richard and Andrew for discussing those special clinical situations. So just going back to the headlines. So any patient who has 5 or more chest compressions and or defibrillation, we're having a procedure under the care of an anaesthetist. If they do tick those boxes, the case is likely to meet the inclusion criteria, every hospital should have a local coordinator who should be contacted, who would then get in touch with the college and be provided with a link to report that case. And clearly, we don't know how often this occurs, and in some hospitals there may be quite a few cases, in others there'll be very few, in some specialties there may be more than others, and that's one of the things that we'll find out from the NAP7 process. And so one of the things we do have is, if there's any doubt on whether a patient should be included, we have a moderator role that, if you get in touch with the college with some anonymous details about the patient, we can put you in touch with the moderator, who will be independent of the actual panel, to discuss whether the patient should be included. But hopefully that shouldn't be an issue for the majority of cases. So I'm just going to move on. So one of the key things about all NAPs is confidentiality, and all the reporting structures have been set up that we can't trace back. So even though we may know a specific hospital has 5 cases, we won't know which 5 cases they are out of the 200 or 600 or whatever we get. And even though we know each hospital's response rate for the baseline survey or the activity survey, we won't be able to link a specific response to any specific hospital or individual. So everything's confidential and anonymous. And the other thing I was going to say is that everything we do on NAP7 relies on, it's a collaboration of every anaesthetist, anaesthesia associate, member of anaesthetic departments in every department in the UK. We're including both NHS and independent sector hospitals. And if you want to know more, you can go to the website and just Google NAP7. You can follow us on Twitter at NAPS, at NAPS_RCOA, or you can email nap@rcoa.ac.uk. So lots of places where you can find more information or ask questions. I'm just going to finish again by thanking everybody for listening and saying NAP7 starts next week. I'm sure it's going to be a great project in terms of improving our learning about preoperative cardiac arrest, how we care for it, and part of the project is going to be about how we both care for the patients and also how we care for each other when these events happen. And there's going to be lots of new learning and recommendations to improve how we care for patients, how we care for each other, and looking forward to working with you all. Thank you.
Thank you very much to Jazz, Amira, Andrew and Richard for those great presentations. I hope everyone's feeling suitably enthused and excited about the formal launch of the project next week. So we've had lots of questions in the Q&A box. A few of them have been answered already, but I'm going to pick up on a few that haven't yet, and maybe come back to a couple that have been answered already, but just for the benefit of the wider audience. So there's most of the questions are about inclusion-exclusion criteria, as you would expect. And we've got one here about a patient who's had a fractured neck of femur, who's had a fascia iliaca block for pain relief in the emergency department and then arrested in the ward or A&E department within 24 hours. Are those patients in or out of NAP7? I'm assuming that they have also been to theatre or not been to theatre. Jazz, do you want to pick that up, please, for us?
I think we've looked into this quite often, and the only patients we're really interested in is where an anaesthetist starts the anaesthesia care. So if the anaesthetist put the block in and then took them to theatre, the anaesthetist has done the block. And ideally we'd pick up every single fascia iliaca block done by every single clinician, but clearly it's not feasible. Most anaesthetic departments won't have wherewithal to know who's done the block and when they're collecting data on these patients. and start the clock. So from our point of view, yeah, we're only interested in those cases which involve anaesthesia care. And I know, Richard, you've mentioned this as well, haven't you, in terms of how we collect this data in emergency department patients?
Yeah, and under the inclusion criteria as written, if it's an anaesthetist performing that regional anaesthesia procedure in the emergency department, then that would be included. But accepting that it might be difficult for these cases to be picked up. But in cases where anaesthetists are performing regional anaesthesia blocks outside of the theatre environment, that procedure under the care of an anaesthetist would count.
Okay, so in many respects, it's mostly about the involvement of the anaesthetist. That's the kind of the starting point in terms of inclusion exclusion criteria for the study. That's great. Thank you very much. So we've had a question about why we're excluding in-house paediatric anaesthesia for critical care, but including retrieval. So Rich, did you want to pick up on this, or Jazz?
I start and then Amira maybe add some points. So the important thing is that NAP7 isn't a study of anaesthesia for critical care. So we weren't including that for either adults or children. But amongst our stakeholder panel that includes the Association of Paediatric Anaesthetists, the Association, the Paediatric Intensive Care Society, there was one group of patients for whom there was concern in terms of what's happening because they're not picked up by any of the current audits. And that was the group of children who present to a non-specialist hospital and then get anaesthesia by the local team, be they adult anaesthetists or paediatric anaesthetists, prior to transfer to a specialist hospital with a paediatric intensive care unit. So this was one of those where, if I'd had my way, we'd probably not included it at all. But, we've listened to, if it's important to patients, important to anaesthetists, so the Association of Paediatric Anaesthetists, Paediatric Intensive Care Society, all think it's an important group, and our patient panel that we need to look into, which is, I'm sure every anaesthetist who works in a hospital with an emergency department dreads being on call for when, a sick baby turns up and they have to anaesthetize them while they're waiting for a retrieval team to come. And that's a group we've specifically looked at as a special criteria. Amira, anything to add to that?
I think you've covered all of it pretty much, but just to reiterate, we're not studying patients that are anaesthetised solely for critical care in adults. And with regards to paediatric, we're making a specialist inclusion for those patients, for the critically ill children that are anaesthetised in centres that do not have a paediatric intensive care unit. So basically a DGH. And are awaiting retrieval to another hospital. Anyone else have anything else to add to that?
No. I think it's important that we're not trying to do work that other audits are already doing. So if these cases are picked up by another audit, we're not necessarily trying to do that, So we're trying to look for areas that aren't covered by existing national audits.
Thank you, guys. So a question here, just to clarify the stop time, as it were, so the perioperative end time. So is it 24 hours after discharge from recovery? Yes. Yeah. Handover of care to another clinician, for example, in the intensive care unit?
Yeah.
Yes. Or if the patient leaves hospital within 24 hours?
Yeah. And then delivery of baby is the other one.
Okay,
Obstetrics.
Great. Thank you. That's great. Thank you very much indeed. A question here about deaths post, or rather cardiac arrests post cardiac surgery. So most of the post cardiac surgery arrests are due to ongoing ischemia or heart failure requiring a shock or CPR. Do we need to include those? If the patient arrests during a transfer to another hospital, who should report it, i.e. a cardiac arrest in the ambulance? So two separate questions there.
Andrew, did you want to do the first one and Richard?
So I mean, with regards to cardiac surgery, the inclusion criteria is the same as everywhere else. So any patient who has a cardiac arrest within 24 hours of handover to the cardiac ICU will be included in NAP7, and we understand that that will include some reopenings of chest and some patients who didn't come off bypass very well, and it may be expected that they may not do well on the unit, but we felt that was an important group to include, and the cardiac anaesthetists within the steering panel also felt that was an important group to include. So yes is the short answer. As long as they fulfill the criteria, they have to have 5 or more chest compressions and or be defibrillated.
Thank you. And on the transfer?
So on the question of patients who arrest during transfer, most of the patients in that situation will be excluded from NAP7 on the basis of the anaesthetic that they've received. So, for example, if they're being transferred they've been anaesthetized in ED and they're being transferred for a procedure somewhere else, as per the ED criteria, they wouldn't be included until the point that they got to the receiving hospital. So effectively, during the transfer, they wouldn't yet have entered the eligibility window for NAP7. Having said that, we would hope that cases like that are already picked up and monitored through network transfer services. But those patients effectively wouldn't have fallen into the eligibility criteria.
Rich, thank you very much. So a question here about why we're not looking at patients who arrest in the perioperative period but don't receive CPR because they have a do not attempt CPR order. Jazz, do you want to pick that up, please?
I think if people die and a decision's been made not to start resuscitation, we aren't going to review those cases in detail. I think it's important to say that the activity survey will pick up how often that occurs, because we'll do this 4-day activity survey, so we'll get an estimate, but we aren't specifically looking at patients and where a decision has been made after they've been anaesthetised not to start CPR. And the reason for that was that, if people come in with ruptured aortic aneurysms, lethal trauma, and they die, if a decision's been made not to start CPR, we don't want to spend a lot of time reviewing those cases, and so it's not the group we're interested in NAP7. And when you do these national audits, you do have to draw the line somewhere, and clearly both for us reviewing the data and people reporting the data have to realise that just increase the number of cases we collect. So we've sort of excluded that group.
Thank you, Jazz. My husband very kindly brought me a cup of coffee. He doesn't do that all the time. I think he knew when I was going to be on screen with 130 people. So next question is about whether the baseline survey, whether foundation year doctors doing an anaesthesia module can participate.
Amira, I think they can do. Yeah. Anybody who's in the anaesthesia department at the time of the survey can. Is that right, Amira?
That's correct. And I would put themselves as under novice, basically, or currently undertaking CT1 or equivalent training, i.e. before IAC.
Okay. Thank you very much. A question here from my old friend Milena. Hello, Milena. Nice to see you're here. There are a lot of anaesthetists on a rotation in critical care. If they're taking a patient for a procedure in CT or interventional radiology as an ICU member of staff, will that still count as an anaesthetist involved in the case?
Richard, did you want to do that?
Yes, it will. So that would be counted as a procedure under the care of an anaesthetist. So yes.
Yeah, I think
Brilliant.
Thank
you very much.
Bit of a grey area. There are some grey areas where trainees rotate in and out of anaesthetists. So if you've sent them the baseline survey to fill in because they're a member of your department. Yeah, and they give someone an anaesthetic. That counts.
Thank you. We had a question earlier about people who can volunteer to be moderators and why we've asked only for consultants rather than SAS doctors or trainees. Jazz, can I put you on the spot on that one? Okay,
so the moderator role has happened in the background for all the NAPs, and no one knows who the moderators are, but they've tended to be sitting and they get like their name mentioned in the small print in the NAP final report, and they've tended to be senior, anaesthetists with expertise in the clinical area who are happy to talk anonymously with anaesthetic colleagues from around the country about cases which may or may not need reporting and need to have confidence in that they're giving the right advice to all grades and all hospitals in the UK. They need to have a sound understanding of the specialty. So maybe, talk about paediatric cardiac cases or neonatal cases or complexity. So ultimately, we're restricting it to actually, there is a person spec, to be generally people who are sort of generally senior, may have already been involved in NAPs and are confident giving advice to 300 or 400 hospitals. And clearly, if people want to apply, we will look at all applications, but we have set the bar high because I think it's a responsible job with little compensation that needs to be done by someone who's got a background in, managing, to put, someone who's got a breadth of clinical and sort of managerial experience.
Thank you, Jazz. Okay, so leading on from a previous question about pre-hospital care. So for clarity, I now take my pre-hospitally anaesthetised patient to theatre from the emergency department, continue anaesthesia, and then he or she subsequently arrests. That patient would now be included? That sounds like a bad day at the office.
Richard, do you want to take that?
Yeah, so if the patient comes under the care of an anaesthetist for a procedure within your hospital, then you're correct. That patient would then be included. Yeah. So okay. The question was correct. Yeah.
Thank you. Brilliant. Thank you very much. So an interesting question here about what about following top-ups of peripheral nerve catheters on the ward? So assuming an anaesthetist has gone to do a top-up on the ward and the patient subsequently arrests, would that be in or out?
I'll take that. So we're only looking at the first 24-hour window. So if they arrest in the first 24-hour window, yes. If the anaesthetist did the top-up, yes. And we've been slightly pragmatic on this in that we've put this 24-hour cutoff on. And so hopefully we'll pick up most of these early events, but we may miss rare events. If this catheter within 3 or 4 days down the line and a member of staff on the ward did it, we may miss it. And I think, if it happens within 24 hours or the anaesthetist does the top up and then they arrest, those are the cases we would pick up.
Thank you, Jazz. So a great question here about the sort of process of data capture. So do you have any tips on how we can make sure that we capture all cases in the post-operative period in that 24 hours after the handover of care? Because we all know that it can be difficult sometimes capturing data.
I know Andrew's looked at this, so Andrew.
Thanks, Jazz. I think, so obviously things that happen in theatre, hopefully people will know happened and there will be a high degree of awareness in theatres. And one of the things that we've done within the LC pack, the local coordinator pack, and also on the website is to provide posters for the theatre area, but we also need to think about other areas of the hospital where these patients are going. So in critical care, and also potentially to the wards. So I think there's something to be done, hopefully, at each site to raise awareness of the project outside of the theatre areas. So engaging with our critical care colleagues, engaging also with people like the resuscitation officers who, if patients go to the wards, might actually be the first people to flag up that a patient who's been to theatre has then had a cardiac arrest within a 24-hour period, because it may not necessarily be reported back. And then also to engage with your local kind of incident management people and DATEX coordinators who would be able to look out for these incidents and also feed back to your local coordinator. So I think it's about spreading the word wide, and also asking those people regularly, have they heard anything, or have there been any events that people are aware of?
Andrew, thank you. So
Ramani,
yeah,
can I
Tim,
come in
hi.
there?
Yes,
Hello.
please.
Yeah, I'm for reasons which I'm not going to explain, I'm a late joiner to the webinar. My apologies. I think Andrew's right. I think one of the points to make is that this is perhaps, I mean, all the NAPs have been challenging for different reasons. One of the greatest challenges with this NAP, which doesn't look at effectively doesn't look at one topic, but looks at multiple topics, is the breadth of it, and the breadth and the extent of it. And I think it will be key for local coordinators, for whose work we're very grateful, to form a local network in a way that probably hasn't happened in the past. I think we welcome and embrace increased training involvement in the whole of the project. But beyond that, there will need to be a network to make the best efforts to try and capture those cases that occur within 24 hours. We were realistic enough to understand that we won't capture all of those cases, but we hope we will capture enough to learn the important themes that emerge from those cases. And we're grateful for what people can do. Thanks.
Thank you, Tim. And welcome, it's great to have you here. So question here about, and we're going to start to think about wrapping up in the next couple of minutes, but we've still got a couple of questions in the Q&A. Cardiac arrest during primary PCI in the cath lab, will it be included if the anaesthetists were called in for resuscitation? So they, presumably that means they weren't involved in the case from the outset. Is that in or out?
May I, Rami? Yes.
Thanks, Andrew.
It depends on when you arrive. So if you arrive and the patient is already in cardiac arrest, then the case wouldn't be included. But if you're asked to go to the cath lab and then the patient subsequently goes into cardiac arrest, then it would be included. Even in theory, if you're just standing there watching to support or help resuscitate the patient and you haven't actually actively anaesthetized the patient. So yes, only if it happens once you've arrived.
Andrew, thank you very much. There's a question here about sharing of lead names to help us set up networks in the region. So is there going to be a system of sort of advertising who's responsible for local coordination? Jazz?
All the local coordinators are already listed on the NAP7 website. And I'm going to take this opportunity to thank Laura Cortez, who's actually hidden away on this webinar, who's doing all the work. She's the main person behind the NAP email address, and she's already listed all the local coordinators on the NAP7 website, and we can put the link up in the chat if we've got that, and so that should be possible.
Thank you, Jazz. There was a question about whether there's an expectation that paediatric specialist retrieval services would be expected to collect data. Amira, could you pick that up for us, please?
Yes, so the data will be picked up by the local coordinator. So it'll be at the base hospital who is expected to submit the patient that arrests before the retrieval team arrives.
Yeah, I think the expectation is that the anaesthetic department of the hospital where the arrest occurs does the reporting as opposed to the paediatric retrieval team.
Okay, thank you both. And I think now our final question, which is again about moderators. So can smaller departments have a moderator? Because it's difficult for cases to be anonymous for consultants in small departments because of participation at local incident review meetings. Jazz, do you want to pick that up?
So the role of a moderator, I think there may have been some confusion, is a national role where the moderator acts for the college. So each department doesn't have a moderator. The moderator in the department is in effect the local coordinator who knows the inclusion-exclusion criteria. And then it's the local coordinator who, if they wish to discuss a case or a specific point with someone, would contact the college, who would put them in touch with a moderator to have a confidential chat about whether the case should be included or not. So yeah, the moderator is actually a national role, and whether we need one or more, we haven't decided yet. Previously, for previous NAPs, they've only needed one moderator because most issues have been clarified before a moderator's needed.
Thank you, Jazz. With a few minutes to spare, I think it now is a good time to start wrapping things up. So I'd like to first of all thank everyone who has put in such an enormous amount of generosity and time already to this project. So Laura has already been mentioned. She really is the engine driving the whole machine forward, only recently back from maternity leave, so welcome back, and we're delighted to see you back, and thank you for everything that you've done. The research and audit team at the college, Christine and Jose in particular, and Karen, Tim Cook for leadership overall of the national audit projects, and Jazz for being the national clinical lead for this incredibly challenging project. And really, really special thanks to Andrew, Richard and Amira. We've never had trainee fellows on the NAPs before. It's been a rocky start because of COVID and the fact that the project was delayed, which has been incredibly disruptive to you as individuals, but you've done an amazing job and we're very, very grateful for your support. So now it's over to everybody watching and listening to really engage and contribute to the project for the next year. We know that the previous NAPs have been very, very successful at changing practice and providing new information for how we should look after our patients. So I've got every confidence that this one will be just as good, if not better. So thank you very much and enjoy the rest of your day.
Thank you.